So here we will start with the other topics of obstetric and gynecology and the remaining complications of OBGYN. So we completed the hypertension series. Now we come to urinary tract infection and asymptomatic bacteriuria. Asymptomatic bacteriuria occurs in up to 7% of pregnancy. Okay, and 30 to 40% will subsequently develop cystitis or pyelonephritis if remained untreated. So persistent untreated bacteriuria places the patient at higher risk of preterm labor, low birth weight, and perinatal mortality. E. coli is responsible for 70 to 90% of infections in this case. Asymptomatic bacteria screening 12 to 16 weeks and urine culture on first trimester screening. If you find more than 10 raised to 5 colony forming units, then you label it as asymptomatic bacteriuria. Urinary tract infection, when the pregnant woman has dysuria, urinary urgency, and frequency. Pyelonephritis with same UTI features with fever and costovertebral angle tenderness. Diagnosis, the best initial test, you do a urine analysis with urine culture. Treatment, asymptomatic bacteriuria and UTI. 3 to 7 days of nitrofurantoin is taken to avoid in the first trimester if possible. Cephalexin, amoxiclav, or fosfomycin can be used. Okay, so you do need to treat asymptomatic bacteriuria and UTI in case of pregnancy. What will you give? You will give 3 to 7 days of nitrofurantoin, not in the first trimester. So you will avoid nitrofurantoin in the first trimester because it is teratogenic. Cephalexin, amoxiclav, or fosfomycin. No fluoroquinolones or cotrimoxazole in the first or third trimester. So this is important. What not to be given in pregnancies. Okay, and no fluoroquinolones because they are tetracyclines are of course teratogenic. Do a follow-up culture at 1 week as test of cure. Okay, so you need to check whether they're cleared of all these bacteria. Pyelonephritis, you need to admit the patient to the hospital, give a lot of IV fluids, IV third generation cephalosporin, suppressive antibiotic based on culture susceptibility for remainder of pregnancy, and follow-up culture for test of cure. For the group beta streptococcus prophylaxis during the time of delivery, remember that we do this testing at 34 weeks to check for this patient has got positive group beta streptococcus, and prophylactically we give them IV penicillin. So if group beta streptococcus UTI at any time during pregnancy, you need to give prophylaxis. Intrahepatic cholestasis. Now, this is very common. Maternal pruritus, mainly on the palms and soles. Okay, look for pruritus in the palms and soles and can also present with right upper quadrant pain. Now, this is not a very severe pain, it's a mild pain. Sleep deprivation and steatorrhea. Raised serum bile acids, which is most sensitive. Transiently increased aminotransferases or alkaline phosphorase, and total or direct bilirubin, which are less specific tests for intrahepatic cholestasis. Risk of intrahepatic, there might be stillbirth, preterm delivery, and meconium stain amniotic fluid. How will you manage? You will give ursodeoxycholic and consider delivery at 36 weeks for this case. Remember, intrahepatic cholestasis is more common than acute fatty liver in pregnancy. So this starts with the letter rare. So when you are in a doubt whether it's acute fatty liver or intrahepatic cholestasis, mark the earlier one. It's a life-threatening complication in the third trimester of pregnancy. Symptoms: nausea, vomiting, right upper quadrant epigastric pain with fulminant liver failure and scleral ictus. Labs: you do aminotransferases 2 times normal, increase the bilirubin, thrombocytopenia, DIC, acute kidney injury, and profound hypoglycemia. So here you can see there's no pruritus, okay? There is right upper quadrant pain, this will be more severe. And there is fulminant liver failure with jaundice in this case. Aminotransferases are 2 times the normal, much more than the intrahepatic cholestasis. Increased bilirubin level, thrombocytopenia, DIC, AKI, and profound hypoglycemia. All these are features of acute fatty liver in pregnancy. The treatment will be immediate delivery due to high fetal and maternal mortality. Now, we come to obstetric complications of pregnancy. The first one being ectopic pregnancy, which is most often tubal in 95% of such cases, but it can be abdominal, ovarian, or cervical. The patient presents with unilateral lower abdominal pain and vaginal spotting or bleeding, although some patients are asymptomatic. Associated with etiologies that cause damage to the fallopian tubes include history of PID, pelvic surgery, DES use, or endometriosis. So anything which is irritating the uterus will cause ectopic pregnancy. Differential diagnoses include um, spontaneous abortion, ovarian torsion, PID, and ruptured ovarian cyst. So this is a very good DD. These are very good DDs. Okay, we need to be vigilant whether they are not in any of these in the MCQs. Diagnosis: you need to evaluate for ectopic pregnancy in all female of reproductive age who are presenting with abdominal pain and positive pregnancy test. So this will be your area of suspicion. When will you suspect ectopic pregnancy? Abdominal pain with positive pregnancy test. The best initial test you do is a transvaginal ultrasonogram. Next best test will be a serial serum beta HCG may be used to stratify hemodynamically stable patients in whom transvaginal USG is non-diagnostic. Less than 3,500 intrauterine per liter, you do serial beta HCG until the level reaches 3,500, which is when an intrauterine pregnancy should be seen. Levels in viable intrauterine pregnancy usually rise 50 to 100% in 48 hours. More than 3,500, repeat beta HCG and ultrasonography in 2 days. I think the best one will be transvaginal ultrasonography. Treatment, medical treatment, very important. Methotrexate is sufficient for small, unruptured tubal pregnancies. Surgical options include salpingectomy or salpingostomy with evacuation, laparoscopy or laparotomy. Complications: tubal rupture and hemoperitoneum, which is a surgical emergency which can occur. Let's see something. So here they're showing us the yolk sac and the gestational sac. This is the yolk sac and gestational sac, endometrial stripe, and okay. So normal intrauterine pregnancy and ectopic pregnancy, transvaginal ultrasonography showing a normal intrauterine pregnancy with a gestational sac containing a yolk sac with uterine cavity, a complex mass. Ectopic pregnancy adjacent to an empty uterus. Now these symptoms: pain. Okay, so this is important for exams. What are the mnemonics? Pain, abdominal pain, amenorrhea, or vaginal bleeding. This will denote ectopic pregnancy. So remember one thing, that ectopic pregnancy is associated with abdominal pain. So in your MCQ, look for amenorrhea with abdominal pain, and this will be one of the DTs and a rising beta HCG. Complete versus partial mole. Complete when sperm fertilization of an empty ovum takes place. The karyotype is 46XX. There's no Y component in it. Fetal tissue, no fetal tissue will be seen. Partial normal ovum fertilized by two sperm, and the karyotype will be 69XXY. And in this case, there will be it will contain fetal tissue. Okay. Gestational trophoblastic disease. It's a range of proliferative trophoblastic abnormality that can be benign or malignant. Okay. And benign gestational trophoblastic disease, it includes complete or partial molar pregnancy. So we've seen these two types of moles. Obviously, these are not viable pregnancies. Malignant will be molar pregnancy, which may progress to malignant GTD, which include the following: the invasive hydatiform moles, 10 to 15%, or the choriocarcinoma, which can be there in 2 to 5% cases. Complication of malignant gestational trophoblastic disease include pulmonary or central nervous system metastasis and trophoblastic pulmonary emboli. The gestational trophoblastic disease presents with first trimester uterine bleeding, hyperemesis gravidarum, preeclampsia or eclampsia at less than 24 weeks, and uterine size greater than dates. Risk factors include extremes of ages less than 20 or more than 40 years, and a diet deficient in folate or beta carotene. So here you can see molar pregnancy. This is the uterus and shows a large complex intrauterine mass. Characteristic with cystic region. So these are cysts in it. Appearance of grapes, also known as snowstorm appearance. So a lot of times this will be a part of the MCQs. The snowstorm appearance of molar pregnancy. So age is less than 20 or more than 40 years, and a diet deficient in folate or beta carotene. Initial test pelvic examination may reveal enlarged ovaries, bilateral theca lutein cyst, or expulsion of grape-like molar clusters into the vagina. Next best most accurate test, pelvic ultrasonography, shows a snowstorm appearance with no gestational sac or fetus present. Labs showed markedly increased serum beta HCG, usually more than 1 lakh. Well, MIU per ml. X-rays of the chest may show lung metastasis, and DNC shows reveals cluster of grape tissues. Treatment, best initial treatment, evacuate the uterus with DNC. Follow with weekly beta HCG to undetectable or negatively weekly, and then monthly for 6 monthly. Contraception for at least 6 months. Okay. So what will you do? You will have to evacuate the uterus, and you have to follow up with weekly beta HCG. And then the target will be undetectable, and then monthly for 6 months. The patient needs to take a contraception for the next 6 months. Treat the malignant disease with chemotherapy, methotrexate or dactynomycin, and treat the residual disease uterine disease with hysterectomy. Okay, so you do hysterectomy for this test. Chemotherapy and irradiation are highly effective for metastasis. Very important topic is antepartum hemorrhage, and this we'll cover in the next episode.